antipsychotics. The only difference is that they also have affinity for 5-HT receptors. They show to be like effective or have some efficacy on negative symptoms, whereas the typical antipsychotics, they don't. They're only good for the positive symptoms. They have the reduced risk of extrapyramidal with side effects, which I'll talk about in a bit. So they're less sedative than the typical antipsychotics. They're also the depot antipsychotics like piprazole or olanzapine. However, clozapine is a dirty drug because it binds to many receptors, as I said, so it binds to D4 and D1 more than D2, which is supposed to be blocking D2 receptors that causes the psychotic effects, but it has a problem with agroleucocytosis. And do you know what's that? Can anyone tell me? What's agroleucocytosis? Hello? Are you guys sleeping or you still there? Yes, low white blood cells. So because of that, so the patients become prone to infections because there's a reduction in white blood cells. So we don't usually give them unless in patients who are resistant to other treatments. Does anyone have any questions until here? Sorry that I'm the one who's doing all the talking here today. Okay, so if there's nothing, if anything that I can clarify, just let me know. So I put a summary table here of all the drugs and how they function. It's a complicated, well, it's not, I hope it's not that complicated, but I'm just gonna explain what these numbers mean. So for example, amisulpride, it blocks only D2 receptors and D3 autoreceptors. It has no affinity for other receptors. Aripiprazole, it's a partial agonist. So it blocks 5-HT1A, 5-HT2A. It's antagonist at the 5-HT2A, but partial here. And the dopamine. So it's known as also a partial agonist. So clozapine, as I said, is the dirty drug receptors. And chloropromazine is the same, but it has no. It's a first generation antipsychotic, so it doesn't work on the 5-HT. Well, we still don't know. So this is just a summary of like the different types of antipsychotics, but mainly, as we say, like we're interested in them blocking D2 and 5-HT receptors. So let's see the effect of typical antipsychotics on brain dopamine neurons. So the mesolimbic, as I said, increases dopamine that causes the positive symptoms. The mesocortical is the hyperactive, so associated with the negative and cognitive and affective systems, which is where the prefrontal cortex is implicated. So we have the negrostriatal, and this is drugs. These are affected by these are the side effects of the effect of dopamine. So which is Tardif Dyskinesia and EPS. So at the tuberohypophyseal, so these are the causes hyperactinemia. So patients usually takes the typical antipsychotics, they see an increase in their breast size, and sometimes milk is produced. And you see that in both men and women due to their effect there. So usually it takes 3 weeks until the symptoms are greatly reduced. So it doesn't work immediately. It takes a few weeks before we can see any effects. But in general, the antipsychotics, they all block dopamine transmission that actually cause side effects. So they do have other side effects. So for example, they do block alpha-adrenergic receptors, which sometimes cause the postural hypotension, like in risperidone, for example. drugs that block the muscarinic receptors, they cause like dry mouth, blurred vision, like clozapine. Sedation is chloropromazine. Usually the first generation antipsychotics are the one who cause sedation. So only clozapine and clozapine that causes sedation in 50% of patients. Atypical, I said that their main side effects that is the weight gain, in particular olanzapine and clozapine. And because of that, when you see increase in weight, this can lead to other complication, which is obesity, diabetes, and heart problems. And the leading cause of death in schizophrenic patients is actually the side effects of these drugs. So patients usually the drugs, and because of they usually confined, or they have a very lazy, as I say, lifestyle. Usually they are, because they're staying at home, they're not involving in activities, and they're socially withdrawn. So as I said, the blocking of the turbo in infundibular tract it causes lactation, which is cause breast development and lactation, i.e. producing of the milk. The nigrostriatal, which is causing the movement of Parkinsonian symptoms and other complications I'll talk about in the next slide. And the block of dopamine in the medulla is related to the antiemetic effect, so it stops nausea and vomiting. So extrapyramidal side effects are usually due to the block of the mesolimbic pathway, the LEV. So when you block the mesolimbic pathway that alleviates the positive symptoms, the antipsychotics also block the nigrostriatal pathway. This leads to extrapyramidal side effects. So patients, they have dystonia, which is uncontrolled movement of the face, neck, and tongue. They have ocular crisis, so they uncontrolled eye movement, ataxia, and restlessness. So it's just like they become very agitated. They can't sit in one place. They can't control their movement. They're just fidgeting all the time. Also, it causes the Parkinsonian symptoms, so slow movement, rigidity, and tremor. The chronic types of it, so when patients are taking antipsychotics for a long time, they suffer from something called Tardif Dyskinesia, which is it's like here, so they have uncontrolled movement of their tongue, face, and it could become permanent. No movement. There is movement, but the movement is uncontrolled because there isn't because you block the dopamine there. So when you don't have enough dopamine, it leads to these effects. So at the beginning, it's the uncontrolled movement, and later it becomes for their body basically. They are moving, but they don't have a control like normal people. As you see here, for example. So what we give for to help with the alleviation of these symptoms is anticholinergics, the antimuscarinics. So they antagonize the effects of antipsychotics, but they do have other side effects, which is dry mouth, blurred vision, and constipation. Another side effects of antipsychotics, it's the prolongation of the QT. So we know that in the ECG, this is part of the normal heartbeat, which is about 420, but usually we correct it to the heart rate, and we call it the QTC. Probably know about that. So when you have the antipsychotics, they prolong the QT interval. And this one of the things that cause the cardiovascular diseases. So the mainly haloperidol are the typical antipsychotics, they are the main culprit. However, also typical and atypical antipsychotics, they're also involved, but you see major effect with the basic, mainly typical antipsychotics. And also the other side effects is the weight change. So Clozapine and olanzapine, the high risk, usually patients put a lot of weight when they take these, especially these two medications. Moderate risk is risperidone and clozapine. The low risk is amisulpride, aripiprazole, and ziprasidone. So I put this at the end because there's lots of side effects. So you can see that with the antipsychotics, although they have helped with the schizophrenic symptoms, i.e. the positive and the negative symptoms, especially the atypical, but they have huge adverse effects. For example, so the bigger the circle, like the higher the risk, basically. So extrapyramidal and Tardif Dyskinesia, we mainly see that with the dopamine antagonist, the atypical antipsychotics. Weight gain, QTC, so hyperglycemia, hyperlipidemia, hyperprolactinemia, and cardiovascular diseases, insulin resistance. The atypical, the main thing is the weight gain, which causes other stuff like diabetes, hyperlipidemia. Does anyone know what dyslipidemia is? Hello? Can anyone answer me? Do you know what dyslipidemia is? Yes, that's hyperlipidemia. You're nearly there. So it's mainly when you have either increase in lipid, but also it's either an increase in either tricyclics, triglycerides, sorry, or lipids, LDLs. And hyperlipidemia is, as you said, is LDLs and in the blood, yes. So it's increase in the blood. But there's also insulin resistance, so which later causes diabetes. That's a very good question, actually. I think patients, they prefer to take them. So I think I've got something here that is statistics that maybe could help with that. So it says that few patients recover fully following treatment, when they take antipsychotics. And most of them continue to have moderate or severe symptoms that may be aggravated by life stressors. 15% of individuals return to productive life after a single episode. 60% will have intermittent episodes throughout their lives, and additional 25%. So 25% of the patients will not recover from their ability to live an independent life. So yes, they are. It's from these statistics. I think it's good to take them, although the side effects are really debilitating, but the patients are taking them, especially with the new drugs like aripiprazole and clozapine. They have less side effects, and these are the partial agonism. The dopamine is the partial agonism. Mainly it's aripiprazole. Usually the thing is, there's no one rule fits all when it comes to antipsychotics. So usually what psychiatrists or doctors do is try to give patients drug that or oral antipsychotics and try to see if they actually work. If not, then they will have to try different types of drugs until they find something that works for them. So yeah, I think as I said, the patients, they take it because it's they take the antipsychotics because it's a lot better than actually suffer with the with the symptoms, especially the positive symptoms. Okay. So yes, so the partial agonism, as I said, there's no one rule fits all. You just have to try different types of drugs until you see the ones that actually works with the patient. And this is the summary here. So finally is the clinical uses of antipsychotics. So schizophrenia is the major use, mainly the use for that, but they also use for bipolar disorder. So if you remember from the lecture on Thursday, we talked that they're giving as a conjunct therapy with the other mood stabilizers. And they are used, for example, as a rapid tranquilization because they're sedatives. They're used for psychotic depression, mainly Clozapine. Because of their antiemetic treatment, they're also being prescribed. They're also used for Huntington chorea, which is a movement disorder. So haloperidol is the main one to be used. So the positive symptoms are when the patients experience hallucinations, delusions. These are known or paranoia. So these are the positive symptoms. The negative symptoms are the depressive mood, social withdrawal from people, and also cognitive. So they have like impairment in their cognition. So memory, attention, it's all disturbed. So this brings me to the end of the lecture, and I have just got one case study here. So I've got only 1 minute. So I'll just go quickly through the questions. So Jason is a 39-year-old with diagnosis of schizophrenia. He's been prescribed olanzapine, 20 milligram at night. He has become increasingly withdrawn, paranoid, and his partner is worried that he may have stopped taking his medication. Jason is concerned about his weight as he's now overweight. So in the past, he had severe stiffness when he was prescribed haloperidol. That's the case study. So the question is, can someone tell me what's the outline, the dopamine hypothesis of schizophrenia? Quickly, we don't have enough time. Sorry, I know you're writing. Is it the lecture was too much information? Yes, okay. So the increase in dopamine in which it acts on the D2 receptors. Yes, so it's an increase in the mesolimbic, yes. It's hyperactivity in the mesolimbic pathway and a decrease in the mesocortical pathway. Okay, so what type of antipsychotic is olanzapine? It's atypical antipsychotic, yes. So what are any side effects other than the weight? Which is, it was a hint actually in the question that he, yes, so cardiovascular, what else? Yeah, dyslipidemia. Okay. So yeah, well, dyslipidemia is one of the. So what other treatment options? What other treatment would you give him? Diabetes, yes, one of the side effects. So other than olanzapine, since he's putting too much weight. Yeah, aripiprazole would be a good one. So how would you help him choose? Because as I said, aripiprazole is the one that doesn't have, it's the low risk. So aripiprazole and ziprasidone, they're the ones that don't cause an increase in weight. Okay, so as I said, usually, for example, in the UK, what we do is when patients, we have this yellow card that we show them, and we help them to choose. So we, as the same yellow card that I showed last time. So we show them the list of drugs that are available. I'm not asking you to learn all this. I'm just showing you that sometimes the patient themselves are actually involved in choosing their treatment, because they're the ones who better know how the drugs works for them and the side effects. So as you can see, that the ones that don't cause increasing weight is mainly aripiprazole. So usually patients try that first if other ones don't work. Okay, so these are the drugs that people are. So these are the drugs that you need to know about. Chlorpromazine, which is the one that we talked about, haloperidol, clozapine, olanzapine, risperidone, aripiprazole, and clozapine. Okay, does anyone have any questions? I know it's a very, it might not, I don't know if the lecture was clear or if you have any questions. I know there was so much information in there. Okay, at least, so someone is saying it's clear, that's a good thing. You're welcome. So in that case, I'm not gonna keep you any long, so thank you very much. Okay, there's one more. The first lecture had more, maybe. So yes, I will definitely, I'll add a slide with the student formulary so that everyone knows, and then I will update the antidepressant lecture. So if you just go back maybe tomorrow and download the new version of the antidepressant drugs, it will have the student formulary in it. So it will be easier than just emailing everyone, and people will have all of it. So, well, I hope you enjoyed the lecture. Actually, I like antipsychotic antidepressants, maybe because it's my background or my field. So I find it quite interesting. I hope you find it interesting as much as I did. And I don't have any more lectures with you, so best of luck for the exams. Thank you, Sarah. And yeah, if you have any questions, let me know. Thank you very much, guys. Thank you. Bye.